Hi, I'm Steve Tunnell, and this is Ventilation Matters. Last week we had yet another great podcast, a terrific team, terrific group of experts here, and I want to thank everyone deeply for the discussion last week. This week we've decided we wanted to talk about work of breathing of ventilated patients, and that may or may not include strategies for patients suffering from COVID-19. But certainly work of breathing is a very deep and rich topic. And we'll start this podcast talking about work of breathing, and I'm sure it will find its way to other future podcasts as well. And we used to focus on work of breathing in three general areas: the work it took to trigger, the work it took to achieve the target, whether it was flow or pressure, and then of course my favorite and my area of most concern was the work to exhale. And that's how we measured mechanical ventilation mechanically. And while that's logical, because ventilation or work is force times distance, and in ventilation it's pressure and volume, and over a rate over time, that's very important for us to understand. But it really comes down to how we interface the machine to the human. And someone who has a lot of experience in that is Graeme A Court. And Graeme, I was going to ask you if you would jump in and give us your thoughts on work of breathing and what modes are of interest, and maybe kick this thing off.
Thanks, Steve. It's a hot topic, right? Synchronization. David mentioned last week about patients with COVID who are asynchronous, and I'm always interested to hear that, because I mean, the point is, with any mode of ventilation, the patient has to react somehow with it to create the energy. And so we have to look at what sort of mode we're talking about, what sort of machines are in the marketplace, because not all ventilators perform the same way. We know that. Some of them are very slow to respond, which increases work of breathing. Some of them are like stealth in comparison. Some of them use proximal flow sensors to pick up early activities. Some will have, for example, an esophageal balloon, and we also have to think about the endotracheal tube. Do we keep small tubes in? Do we go to bigger tubes? Because we know there's always a gradient across tubes. Do we also look at the algorithms to improve synchrony? We do have algorithms that can increase rise time, because obviously the ventilator doesn't know where the handbrake is. With flow, there's flow to stop. It doesn't to stop. It slows down at a certain point. And also, like Steve mentioned, the volume part. If the lung is now full, when does termination take over? Is the modes of ventilation we're using the wrong modes? I would go back later, Dave, to talk to you or question you a bit more about adaptive ventilation. But that, to me, would be something we should discuss, all these modes, and do we tinker with the ventilators to improve flow or improve synchrony? So, you're the experts. I'm the machine guy. You guys are the experts, right? So the clinicians can start the ball rolling. Who wants to go first?
I'm glad that we have the experts on the machine here. Looking at our very small series of COVID patients who needed mechanical ventilation, we have learned a tremendous amount from them, particularly when we followed in the early stages our treatment of the patient according to the so-called classical ARDS recommendations. And we found that actually that was not such a good learning curve for us. And however, we came across the recent publications and teaching from Gattinoni, and we were better able to use that set of criteria in the later stages. But leaving that aside for the minute, we were also very well aware that allowing the patient to breathe spontaneously is going to be a very possibly a deleterious thing. So we learned early on in our learning curve that we had to really use a lot of muscle relaxation and deep sedation for maybe over a week, and then to judge the right time in order to allow the spontaneous effort to resume was a very crucial part of that learning. And I'm glad to say that we were able to achieve much better results in the latter part of our case series.
Is work of breathing something that you have in your mind when you're managing a patient on a ventilator, or is it something you think about when weaning time occurs? Clearly, the work is something that is applied to the patient or is taken over for the patient during controlled mechanical ventilation, assuming the patient's paralyzed. But is it something that you keep in your mind continuously as a physician?
I think it is in the mind, but in the first instance, while the patient is completely paralyzed, we would be trying to look at the parameters more of recruitability and of achieving the correct things like PF ratio, while at the same time we are watching for the moment when we have to switch over and trying to see whether how is the patient going to take it when they start their own respiratory effort, which implies that there's going to be some negative intrathoracic pressure. And we were very worried about those effects when we start to let the patient breathe, because our earlier cases, our very first case, didn't do so well using that strategy.
I know that some ventilator companies purport one mode for all phases of mechanical ventilation, for committing the patient, for a patient who is fully supported, and then for weaning as well. Do you gentlemen, have you found such a mode? Have you found a mode for all that is out there, or are there different modes that suit different situations better in your mind? And of course, it's dependent on the tool that you have, the ventilator that you have, but in general, is there such a mode?
So Steve, we've used AVM and ASV, the two automated modes, quite early on in ventilation as a starter, as I said last week. And we've used it in the weaning phase. However, for the critically ill, for the very unwell, particularly when there's significant respiratory distress, and certainly in classical ARDS, we've found that ASV and AVM tend to give large tidal volumes. And that obviously works out the work of breathing using the Otis equation and does that for us, but it seems to suggest that a large tidal volume with a slower rate is the best way to do it. Now, I'm very uncomfortable with that because of the risks with large tidal volumes. So therefore, we tend to use a controlled, assist control mode, usually, SCMV on the Hamilton or assist control, volume control on the Bella Vista. And we've tended to do that during the control phase. And as Patrick said, for the first 2, 3, 4, maybe 6 days, depending on how well they are, we control it. When we start to wean, we often go to ASV or AVM as a mode to allow them to move to spontaneous breathing. The timing of that is difficult. It's certainly, I don't think it's done on work of breathing. It's more done on oxygenation and other parameters, and including hemodynamic stability. You were talking before about the work of breathing. I think we do think about it. You certainly watch it in unventilated patients. In ventilated spontaneous breathing patients, we worry about it. And I think we think about it with controlled mandatory ventilation, but we don't have a number. It's hard to quantify. And it's a bit like afterload. The most important thing in cardiac output is the afterload. But we don't measure it. We can't measure it. So we have surrogate measures of it. And I think it's the same with work of breathing. Because we don't have a number to say this is so many joules being expended, we don't have a number we can measure. So therefore, it's a concept, and if you're right, increased work of breathing in the notes, but there's no number to put down, and there's no way of quantifying that, so that tomorrow I come back and say, well, it's less. It's now 6 rather than 5. So there's no way to do that. So and I think that makes it difficult. So it's a conceptual idea, but quantifying it's difficult.
David or Geoff, do you have any thoughts?
Yeah, I mean, my experience has been kind of the same. I mean, prior to COVID, I would say that we probably set up most of our patients on, because we have Hamilton Galileos and G5 ventilators, we probably set up most patients initially in adaptive support ventilation. And as long as you set the patient demographics correctly, most people who are post-operative or have normal lungs or minimally abnormal lungs will do fine with that. But the patients who had acute lung injury, ARDS, typically we would not use that mode. And in the COVID patients, they all have a version of ARDS or acute lung injury. They all have very high respiratory drives initially. So we haven't had any success with using that early on when they're intubated. We typically are sedating them heavily. Most probably are paralyzed, and so we're using APV, CMV, or what other ventilators would call PRVC, pressure-based volume mode. And then at some point, as they're recovering, I'm finding that ASV turns out to be pretty good for them, as long as they're not still in that hyperactive phase of very high respiratory demand. And I share the same concerns that Ross has with the potential in ASV for the patient to have very large tidal volumes that exceed what we think may be safe and probably inducing lung injury.
Geoff, you were going to say something?
Yeah, I was. We're actually discussing a whole lot of different concepts and conflating them all together, and therefore it becomes actually quite confusing when you're trying to sort out what's going on. I've just made some notes. When we talk about work of breathing, we've got to understand that we can be talking about the imposed work of breathing by the machines and the intrinsic work of breathing by the patient. We've got to separate those two things out. And we need to understand, what is it about the work of breathing that is actually bad? Is it because the work of breathing increases lung strain? It's the lung strain either regionally or globally that is associated with bad outcome. And it's actually quite difficult putting all these concepts together. We speak about these things that sort of flow off our tongues, but trying to pull all this stuff apart and deconstruct it so it actually makes sense is actually quite tricky. So I guess my approach is to go right back to saying, what are we trying to do here? And in the main, what we are initially trying to do with patients who've got acute lung injury is to minimize ongoing lung strain. And we can discuss for hours how we might achieve that optimum. Then we start moving into a phase where the patient starts to breathe by themselves. What are the objectives of that? Well, they're severalfold. Again, you want to minimize the lung strain whilst they're coming through that weaning phase. And in doing so, you've got to obviously focus on dysynchrony, because dysynchrony is associated with unknown trauma to the lung, because of the interaction between the patient and the ventilator will end up causing regionally increased lung strain there as well. So dysynchrony, the work in breathing that is imposed by the machine itself, and we can just, I think that the types of modes that we have discussed have a small part to play. I think that the biggest problem that we have is that we still are dealing with a brain, a human brain, that is actually receiving the wrong inputs and producing the wrong outputs, which cause ongoing lung injury. And the work of breathing that we see is this sort of conflated integral of what the machine's doing, what the patient's brain is telling the rest of the body to do, and the net effect is some sort of ugly mess, and oftentimes. So it's actually a really difficult thing to navigate through. I would propose that when we think about it, we've actually got to deconstruct these concepts so that we absolutely understand what specifically we're trying to do. We're concerned about ongoing lung injury, and we believe that in the weaning process there is a high respiratory drive. We're concerned about Marcello Amato's concerns about the peridiaphragmatic regions of the lung, which are exposed to enormous lung strain because of pendulum and the like. Then we need to back off on those modes of ventilation which will create that risk. And so it's one of those cases of just having sort of, navigate your way through this forest of challenges. There's the other concept we talked about is the concept of mechanical power, which again is quite different from worker breathing. That's a concept that's trying to put together the bad impact of lung strain, the absolute amount of peak the patient has, and I have the equation in front of me. It just relates to the equation of motion, but the dominant factor is the delta V squared. So that is by far the more dominant part of the mechanical power, which is obviously your tidal volume. Again, I think we're all looking for some magic number. I don't think we've got one. And I think it depends on us to try to figure out what is important at that time when we're managing a patient. If you've got a fit, healthy person who's taken a drug overdose, it doesn't matter how you ventilate. They will do fine. But it's those people who've got vulnerabilities that we need to sit back and assess each day and make sure that we're moving in the right direction. We haven't even discussed in the worker breathing things like the imposed worker breathing, someone who's got airway, gas trapping and the impact that has.
Geoff, you mentioned the problems of work of breathing and the power. I have concerns about the formula that people use because they take into the equation of motion, and when it's reasonable to talk about that as the power required to drive a ventilation system. But we're talking lung strain and alveolar damage. Often a lot of the energy that's transmitted to the lung is lost in the turbulence and resistance in the large airways. In fact, the majority of the energy lost is in the upper airways. Now, when patients get ARDS, they don't get ARDS of the trachea or the bronchioles, they get it in the alveolus. So I'm at a loss to understand how that energy becomes a strain problem for the alveolus. And I think because we've gone for lower tidal volumes at subsequently faster rates to maintain the same minute ventilation, there's a double penalty for patients that have a poor compliance because the energy that's transmitted appears to be to the alveolus appears to be much higher because they are getting more frequent breaths at faster rates, and so more energy is transmitted to the outer airway rather than the inner airway. So although we can show correlation with damage between high energy stakes and alveolar damage, I'm not sure that one causes the other. I think that a lot of the increased energy that's transmitted is lost in the resistance in the outer airways. I just wondered what you thought about that, because I have some, if you read Amato's original paper, he doesn't say some of the things that people quote him as saying. They talk mainly, he talks about the fact that compliance is associated with poor compliance is associated with badness, and therefore the driving pressure is associated with a poor compliance. And then this is that rather than saying that the pressure is the problem. So,
yeah, I can answer that, Ross. When you talk about you're interested in the resistance in the central airways as being the biggest contributor, that is actually subtly taken into account with the dynamic elastance, or the ERS, the respiratory elastance. Because when you measure it, you cannot extricate the resistance of your upper airways from that equation. So the power equation is not a pure thing. It actually has other metrics within it, which include these sorts of things. I'm not, the bit I have with, the problem I have with the power equation I've never quite accepted is adding in the static number called PEEP. I know the reason is, well, you know, if you've got a whole lot of PEEP on, you've got a lot of strain, therefore that's bad for your lungs. But in taking that into account, the elastance that you measure in a lung that's recruitable will be minimised at the optimal level of PEEP. And I've never really been convinced that you should add in a static amount of lung strain into this power equation on top of the other metrics which make it up. But the biggest and most important one is your volume squared, the lung strain squared. And the elastance is in there, but it's a, how would I say it? It's a measure of both the specific elastance within the patient's lung, as well as all the resistive elements within that lung that will give it an apparent stiffness. That makes sense. So I think it does actually account for it, Ross.
Yeah, well, I mean, on another matter, I mean, it takes into account all the energy transmitted, including that used to move the lard that is, you know, the obesity lard, which is clearly not transmitted through the lung if you've got a high pleural pressure. So the equation of motion takes into account the extra energy required to lift the fat the patient has, which is not damage to the lung. So I think there's a lot of variables, and if you apply it to different groups, you'll give different results. There's the correlation between driving pressures and the morbidly obese is not as strong, possibly because the driving pressures are used to overcome the weight of the lung wall rather than the lung, and I think there's some issues there as well. But the equation does does include the resistance of the airway, and that is not something that we see with ARDS as being damaged by that. And as I said, once the flows get high, because the rate is fast, you hit twice, because you get hit for the number of breaths per minute is energy transmitted to the lung, and because the flows are higher, you're being twice punished for those energies appear to be much higher, and none of that energy is transmitted to the alveoles. So I fail to see how, although it might be associated with, I can't see how it's causative, and it's a lack of logic in the causation. As far as the PEEP's concerned, when you use the equation of motion, you can either remove PEEP and say that the volume you're talking about is the total lung volume divided by the compliance, or you leave the PEEP in and say the volume that's being used is then the tidal volume that's being used, and it's open to interpretation which one's better. And in different circumstances, I think you can use the volume being the total lung volume, and therefore, if you're looking at the strain on the lung, possibly you should remove PEEP and use the end expiratory lung volume or plus the tidal volume as the volume. And if you're going to take out, you use the PEEP, then you use just the tidal volume as in the equation. And it gives you different answers, but it's the same. You have to take into account the fact that the lung is not empty at the end of expiration. Otherwise, the dynamic effect of PEEP disappears in the equation.
Nothing more, Geoff. So I'll jump in if I can. What do we think about still improving synchrony? Because we've discussed power and a bit about PEEP, but like, are there modes that we could be using that could improve synchrony at all? I mean, even with our existing modes, do we actually titrate them? Do we, for example, with pressure support, do we look at rise time control? Or do we look at the PTP? Is the machine responding fast enough? There's lots of things we can do, but are we doing it? I mean, what do we do at the bedside? Right?
Yeah. I think it's a really interesting question, because empirically we know dysynchrony is associated with worse outcomes. That's just observational studies. We know that it's associated with increased lung strain. Just physiologically, it must be because you're not synchronizing the patient and the ventilator. You're going to get intermittent breath stacking, etc. It's all been well described. But again, when you're looking at trying to synchronize a patient's breathing, you are actually you're giving priority to the neural connections between their brain and their lung. And you're saying that is now going to trump everything else. And it actually may be a bad thing to do. Because if you've got someone with very high respiratory drive and you spend all your time focusing on improving synchrony, you might then just be ending up chasing the patients chasing their tail and ending up with uncontrolled very high tidal volumes and very high rates. For example, if you get a patient who's on non-invasive ventilation who comes in with, say, asthma. I had a patient like this a few months ago, a young woman who said she was terribly distressed and she had a CO2, which is probably in the mid-20s, and a minute ventilation of about 30 litres a minute. And I remember thinking to myself, well, this is crazy, and yet everybody was, tweaking the ventilator knobs to make it easy for the breathe. Oh, she's a bit more distressed. I better actually give her a bit more driving pressure here. And so you can actually do a lot of harm by just pandering, if you like, to the dysfunctional state of the patient's neural control of breathing. So I think the synchrony must be, when we talk about it, we must also pull out from that the concept that it is bad to support a patient's breath if in doing so we injure the lungs. And therefore, that's when we have to make the decision to take over the breathing and reventilate them, paralyze them. But in those patients who are beginning to breathe by themselves and we judge that their neural control of their lungs is not going to injure their lungs, then having correct synchrony is going to be very important for that person. And how that's achieved, well, we've got dozens of solutions to that, which you will be more famous than me. So those are my thoughts about synchrony. Again, it's just one of those things we can't think about it in isolation. We've got to understand the whole sort of total package.
David, what would you do? In your example last week where you mentioned about this patient who was showing dysynchrony, large tidal volumes, was it just really the patient was too active, or it was in fact just based on the lung mechanics?
Well, I couldn't agree more with Geoff. I think there are patients, and we're seeing them now, but we've seen them for years, even before COVID, whose respiratory drive, for whatever reason, is so high that no matter what we do with the ventilator, they're either going to be dysynchronous, or if they are synchronous, they're going to be injuring their lungs. So someone who is markedly acidotic, diabetic ketoacidosis, we don't want to give them everything that they want. We really want to either correct their acidosis, which will obviously slow down their demand for minute ventilation, or we have to control their breathing and sedate them. We wouldn't do that in DKA, but for example, but many other conditions. And we're seeing that in COVID, and I'm seeing some of these patients who are recovering, who suddenly have these very high demands, and I'm adjusting their trigger sensitivity and their rise time and their expiratory flow termination if they're in a pressure support mode. And that's not going to do the trick if their real problem is neurally mediated or lung-mediated drive to overventilate. And in those cases, the answer is really going to be sedation and maybe paralysis. So I spent a lot of time with the ventilator trying to manipulate those parameters to try to make patients more comfortable and synchronous, especially when I feel like it's not just their drive to breathe, but I think you have to recognize when it's not a machine problem and it's the patient problem.
David, would you, in the ASV mode, would you actually look at increasing the minute volume support to try and increase the mean pressure? To make them, for example, if they're breathing, say, you have 7 litres per minute set, okay, that should be fine for a normal patient, but they're breathing at 12. Would you increase the percentage to try and target that sweet spot?
Not necessarily. I'm not really sure when I would do that, per se.
It's a provoking question, don't worry.
It is. It's really really hard to come up with a specific answer to that. Obviously, there's a certain amount of trial and error and trying at the bedside and seeing what happens.
Why I say it for, because if your choices are PCV, so we've got control of pressure, but volume's all over the place, volume control or cyst control, like Ross likes to use in the early phase, but the airway pressure can be all over the place. If you target just tidal volume, and we're using a mode like PRVC, but it's a negative feedback system. So what happens, they get their volume, but the machine is trying to lower the pressure back the whole time, so that impacts the mean pressure, actual pressure, mean pressure is decreased. If we use adaptive ventilation, either ASV or AVM, then what happens is it's the same concept. As the volumes are quite high, the ventilator starts to reduce pressure, mean pressure, their work of breathing increases. I'm just saying, should we look at maybe trying to match what they want and see if the mean increases and they slow down?
Yeah, Graham, I think that's a really important concept. I mean, generally what we're talking about is unloading and reloading the respiratory muscles. Yeah. And we know this. You can play with the ventilator, and in a patient who is getting assisted spontaneous breathing delivered by whatever mode you choose, you'll see this interplay. And at the end of the day, the patient's tidal volumes and respiratory rates will often be the same. But all you've done in process is you've actually transferred more of the work to the patient or back to the ventilator. Yep. So then we've got to consider the trade-off. Now, what we do clinically is, as Ross alluded to earlier on in the conversation, is we look at the patient, we look at their heart rate, look how much sweat, look at the nasal flare and all those other things. And we ask ourselves, is this patient looking happy? And they're not looking happy, we think, we better reventilate them a bit more. And I mean, crudely speaking, that's probably about the level of sophistication we have. But we can measure we can pull apart how much effort the patient is putting in and how much the ventilator is putting in. And thus it might be a useful metric to consider, each one of those factors separately to try to work out for an individual patient what actually is best for them. The other thing is that when someone is spontaneously breathing versus someone who is spending more time receiving assistance from the ventilator, they are quite different in terms of the regional lung stress. So the spontaneously breathing patient will be generally straining the juxtadiaphragmatic regions of the lung a bit more, and we have to be cognizant of that. So again, it's not simply just a trade-off between how much work the patient is doing and how much work the machine is doing. We've got to look at the in a more granular way, what is exactly happening to regional lung strain, if that is indeed a problem. So yeah, it's a complicated bloody thing, which is why we're talking about, I suppose.
Well, I did hear you guys basically set as a marker neurologically intact patient assessment. Assessing them to be neurologically intact is an important point in the decision to put the load of mechanical ventilation onto them, or at least to let them try. And I wonder, in the COVID patients, I heard from Dr. Tan last week, and I've heard from David, that these patients seem to be extremely exhausted once they've been, not just, the issues per se from being out for a week, but when they do start, and I've heard this about patients even being discharged, it seems like it's taken a lot out of them, and that there's an extreme sense of exhaustion. So you mentioned just a minute ago, Geoff, that you're looking for the happy patient. Do you see happy patients with your COVID patients once they're over the hump and you are withdrawing mechanical ventilatory support? Do they seem more difficult than generally speaking healthy patients that you're weaning that may have been on a ventilator for some other reason? Patrick or Dave, do you feel like these patients are different and that the weaning process is prolonged or requires more care than general? What are your thoughts there?
Looking at our patients at the point where we felt that we could attempt to let them start to wake up probably from about day 7, 8, or 9 onwards, we were very mindful of not treating them in the classical ARDS way as to get them off quickly, but instead to be very wary that it had to be done extremely cautiously, extremely slowly. So during that phase, we allowed the sedation effects to be really titrated away, weaned off, make sure that they are not confused or disoriented. And then we did find that the level of cooperation was pretty good and that they understood all the instructions, and we watched them very, very carefully. I think our very small numbers of patients, we didn't encounter a lot of extreme exhaustion. It perhaps took another 3-4 days of very slow weaning, and then we were able to achieve a trial of extubation.
Can
So
I ask you?
Yes, I can't answer whether they were actually happy, but I think they looked reasonable.
It's really hard to answer that question. Do they look happy? I've got a question for those that have managed COVID patients. As you know, and we don't have any cases in New Zealand, even in hospital at the moment. I want to know about what happens to patient weakness and how that is different in COVID patients versus other patients with ARDS. I've always been suspicious that the critical illness weakness that is so common is in fact a godsend for many patients, because they can't tear their lungs apart when they're actually in the recovery phase, and they don't have a powerful diaphragmatic force that causes ongoing lung injury. So would you like to comment about critical illness weakness in COVID patients by comparison with other non-COVID patients?
I would only say that our numbers, we've been extremely lucky. We haven't encountered things like critical illness neuropathy, even though they've been on relaxants for over a week. We got them off, and they did seem to have sufficient muscle reserve to perform the weaning according to estimation.
That's interesting.
I think I think we have seen a number of patients who definitely have, a critical illness polyneuropathy or myopathy, typical of what we've seen before. Not all of them, but I would also echo the notion that we've really learned kind of in the hard way that these patients typically require a longer period of weaning than our traditional, our current traditional approach, which is, daily spontaneous breathing trials and extubate them the very first time that they can breathe for an hour or two spontaneously, because we've had to reintubate a few people who, after extubation, exhibited excessive work of breathing, and we tried to tide them along, and they failed. And I was listening to an interview with John Marini, just last week, where he echoed the exact same thing in his experience in St. Paul, that these patients need a bit of a longer period of weaning than what we're accustomed to doing in most of our critically ill patients. They take a long time, some of them, to get to the point where they need to be intubated and mechanically ventilated, because we're using other modalities like high flow nasal cannula. And so we'll see people go now 4, 5, 6 days, then fail and get intubated. Then they're on the ventilator for 2 or 3 weeks, and they're taking a little bit longer period of time to be comfortable, extubated and breathing spontaneously. So I don't know what accounts for all of that, but it's an observation that others have made, and now I'm seeing the same thing sort of replicated in my patients.
Hi, everyone. This is Steve. We had a great discussion migrating from work of breathing, talking about some modes of ventilation, and then focused on weaning. We're going to call it quits here, and we're going to pick up this dialogue on Ventilation Matters 4. So take a break and jump on to Ventilation Matters 4. We'll be talking about weaning and the information race of ventilation. See you there.